About 15% of the total population of people living with TB are children. And we understand that screening children is not as easy as screening an adult. How are you working around to ensure that you actually capture the infection within the young ones as fast as you can and then enroll them on treatment, but also is the treatment the same as for adults?
Okay. Yes, diagnosis of tuberculosis is not easy. Even in adults, sometimes we miss it as health workers. But when it comes to children, it is even much more difficult, especially the young ones below 5 years, who cannot expectorate the sputum, and we test it in the lab. So how have we gone about improving the screening in this population? One, we are building capacity of the health workers on how to combine the different signs and symptoms to help them in coming to conclusion of TB, especially in those where they cannot pick a sample. But also, most recently, we have introduced the use of stool. The very young ones, when they cough, sputum comes up, they swallow it. So this sputum will go with the germs in the stool. So the gene expert can be able to now detect this TB by when the health workers process this stool, they can identify that germ. So last year we introduced the use of stool. We call it simple one step for testing TB in children, and it is rolled out across the country. You can send the stool sample to the gene expert site, and then they will test that child for TB. But also using X-ray services to support the different signs and symptoms for you to make a conclusion. If in the lungs there is a sign within the lungs that shows that this child may have TB, also helps in making the diagnosis much quicker. The treatment, we use the same medicines for treating TB in children and adults. Now the duration is the one which we have reduced. For children who do not have severe disease, we have started looking at reducing their duration of treatment from 6 to 4 months. We have initially started with the regional referral hospitals because there is a criteria that you follow, including the use of the chest X-ray to rule out severe lung damage. And we know that this is more available at that level, and we should scale up this to other hospitals that have this service to make sure that children without complicated TB are given treatment for only 4 months.
We have a couple of people who are suffering from or suffering with multi-drug resistant TB. About 4 of every 100 have MDR TB. How is the ministry dealing with the drug-resistant TB in terms of treatment, but also screening and establishing these groups of people?
Yes, drug-resistant TB is also a challenge. Although Uganda is not among the highly burdened countries with drug-resistant TB, it is still a big challenge. We estimate that every year, of the 90,000 individuals that fall ill with TB, about 14 to 15,000 have 1,500 have drug-resistant TB. I beg your pardon. And we have not done well in terms of identifying all those patients. It was only in 2022 where we crossed to about 700 individuals with drug-resistant TB. And this was because we implemented the CAST campaign and emphasized the testing for people whom we pick samples from at the gene expert sites. The gene expert machine is, and now TrueNut machine, which is also a smaller version of the gene expert, are the only community level testing services that we have that can detect drug resistance. So if the patient's sample is not tested on these two modalities, it is not easy for us to tell that the TB they have is resistant TB. But we have encouraged everyone who is making a diagnosis of TB to make sure that they rule out resistance. Even when the microscope is the mode of diagnosis, when you start TB treatment, send another sample to the gene expert site so that as the patient goes through treatment, you are able to tell whether the TB they have is resistant TB or not resistant TB. Unfortunately, this is not yet happening for all patients. We are at about 70% of TB patients who are diagnosed generally getting the rifampicin resistant status of their TB. We are calling upon all healthcare workers to make sure that every TB patient, while on treatment, they get their resistant status known so that we can change treatment in case they have the resistant strain. So the gene expert machines are available across the country in about 320 health facilities, and we have a very robust hub system which can move samples from even a health center to the gene expert site wherever it is so that the testing can be done. And during the campaign, the only expected testing modality for the samples, the sputum and the stool for children, is the gene expert, the TrueNut, and the LAMP machine. We don't expect other microscope testing because we are reaching people at community level, and we want to use the opportunity to be able to get the TB in case it is there. The microscope will miss a lot of patients if we use it, and we also not be able to tell us the resistance status.